What's up, folks? Welcome to another high-speed VMR case recap. We missed a week, which is actually kind of a bummer because I really realized how much uh, learning is had when you recap the cases that we did. And so there was nothing like missing last week to remind me, at least, of how powerful this session is for my learning and hopefully yours. And as always, we're a little bit crunched on time, so we'll jump right in. And this time we don't have a Sunday VMR recap, so we'll start with a fascinating case on Monday that Madalena will recap.
Yes, okay. It indeed was extremely fascinating. I definitely echo that. Having to go through and prepare teaching points for this was so helpful for me. So I, get to summarize Monday's case, which was presented by Mohit and discussed by Gurpreet Dhaliwal. So I'm first going to summarize the case in 2 sentences, and then I'm going to give 2 teaching points, and we're going to do this quickly. So the 2-sentence summary is that this was a case of a 76-year-old man with multiple comorbidities, including uncontrolled diabetes, who was admitted for treatment of otitis externa that had not resolved for 2 months, treated with cefepime in the hospital, and then subsequently on day 3 of hospitalization developed altered mental status and myoclonus, all concerning for cefepime-induced neurotoxicity. Ultimately, the patient's altered mental status and myoclonus resolved with cessation of cefepime, and then further imaging showed evidence of osteomyelitis with these bony erosions. So the final diagnosis was cefepime-induced neurotoxicity, and then otitis externa complicated by osteomyelitis, which I believe we can kind of classify as malignant otitis externa. So jumping to the learning points. So the first learning point I want to go over is this 5-part framework for a non-resolving infection that Gurpreet walked us through. So I'm going to go through kind of the 5 prongs of that framework, and then we'll do like a quick example for each of those. So the 5 prongs quickly are, if the antibiotics appear to be failing or the infection is not resolving, you can think, do we have the wrong bug? Do we have the wrong drug? Do we have the wrong diagnosis, the wrong host, or is it a source control issue? But then even before going through all those prongs, and this kind of came up in the case, you want to make sure you ask the patient, and in some cases the family, to what extent the patient actually has been taking the medication, because that was actually the case in the case. So for some quick examples, so if we're thinking of a wrong bug, an example of that is, say the team is prioritizing a bacterial infection, but appears to not be improving on antibiotics, then you also want to be open to the possibility of other bugs being the cause. So Gurpreet talked about viruses like HSV, mycobacteria, like tuberculosis, and even fungal causes like histo. And you also want to be open to the possibility of a wrong diagnosis. So in this case, be open to the possibility that it's actually an alternate process that's not infectious. So in this case, we talked about examples of malignancy like squamous cell carcinoma, or even an autoimmune cause that has a predilection for the ear like GPA. So then the third category is wrong drug. So in addition to asking, is the patient even taking the drug, and what is the dose? Is it the correct dose? An example of when it could be the wrong drug is, say you've narrowed in that Pseudomonas is most likely, but the drug you're using doesn't have pseudomonal coverage. What are we at? Fourth. The fourth bucket is source control. So an example of this is, say we have an infection that has spread to a place where it's not actually being drained properly. So some of the examples we went through were an ear infection could spread to the mastoid or temporal bone, or even go to the brain and cause things like encephalopathy or meningitis. He even talked about vascular complications. And then the last bucket, number 5, is the wrong host. So what this means is maybe you've misjudged the host in terms of their immune competency. So an example of this is, perhaps you didn't realize that the patient was somewhat immunocompromised by a medication they were taking, like a steroid, or even some underlying disease like uncontrolled diabetes or HIV. And we've actually talked about in other VMRs that kind of this doesn't take the spotlight away from the most common pathogens, but more just widens the spotlight on the types of bugs that you need to consider. Okay, so that was a whirlwind of teaching point number 1. And because we're going fast, I'm going to jump into learning point number 2, and then we'll have some time for questions. So the learning point for number 2 is I actually wanted to do a brief overview of like an illness script for cefepime-induced neurotoxicity, because I had no idea, I had not heard of this, and it was just so fascinating for me to dive into it. And so before jumping into cefepime-induced neurotoxicity, I did want to highlight that this is not unique to cefepime, and in fact, there's a whole entity called antibiotic-associated encephalopathy. And Gurpreet actually walked us through the 3 major classes of antibiotics that have been described to cause this. So the 3 classes he talked about were the beta-lactams, the quinolones, and actually metronidazole too. So now if we focus in on the beta-lactam category, if we remember from classes on antibiotics, so beta-lactams are a group of antibiotics that have this beta-lactam ring in their structure. And it includes things like penicillins, carbapenems, cephalosporins. And so now if we focus in on cefepime, which is a type of cephalosporin, we can kind of jump into the illness script for that. So cefepime, it's a 4th generation cephalosporin. It's a broad spectrum antibiotic, meaning it covers gram positives and gram negatives. And then importantly for this conversation, it can cross the blood-brain barrier. So it can be used to treat meningitis, but also can cause neurotoxicity. And it's renally cleared, which we'll circle back to. So as all illness scripts, if you've seen the videos that Reza makes, he likes to start with the why. So we're going to start with the why. So the take-home point here is that there's actually a structural similarity between the GABA neurotransmitter and the beta-lactam ring. And because of the structural similarity, the beta-lactam ring in cefepime can block the binding of GABA to the GABA receptor. And so to highlight this, I actually wanted to share my screen to show you the structural similarity, which was kind of cool to look at. It also gives me an opportunity to highlight what I found to be a really helpful resource, which was the Curious Clinicians have an awesome podcast on it. But you can see here that they've kind of highlighted the parts of the structural similarities. So I can just stop my screen. I just wanted to show you that image because it was helpful. But so going back to kind of the pathophysiology here. So if we remember, GABA is an inhibitory neurotransmitter. So by blocking the inhibition, you actually get neuroexcitation, which ultimately can lead us to kind of the what in this illness script. So if you have neuroexcitation, that kind of explains a lot of the typical features that you have, like myoclonus, which we saw in the case, tremors, seizures. So another important point here is that it can be like a broad spectrum of manifestations. And then, going to kind of the who and the risk factors, this also relates to the pathophysiology because the blockage of the GABA receptor is actually concentration dependent. So in other words, the higher the concentration of the beta-lactam, the more it blocks the receptors. So kind of given that, I actually wanted to see if the group, you may know, but could come up with what would you predict to be like one of the biggest risk factors given this kind of concentration dependent receptor blockage? Any thoughts, you guys? Yeah, okay. So Mukund said impaired excretion, AKI, CKD, exactly. So the biggest risk factor is renal dysfunction. And I actually saw there were kind of 2 reasons for that. A lot of what you said in the chat, like decreased clearance and increased serum drug levels, so then more can cross the blood-brain barrier and block the GABA receptors. And then another one is kind of the metabolic derangements you can get from AKI. So you can maybe get hyperkalemia, and then you're just predisposed to having the neurotoxicity. I also saw age is also a risk factor, but maybe not as significant as the renal dysfunction. So kind of in summary, this diagnosis can be kind of difficult to tease out because there are so many things that can cause myoclonus, so many things that can cause altered mental status. But basically, you just want to have this in the back of your mind, especially when someone's on cefepime and considering like the timing of the drug initiation with symptom onset. So if a patient on day 3, 4, 5, 6 of cefepime develops altered mental status and the rest of the workup is negative, it's just something to consider, stopping an antibiotic and seeing if it resolves. Okay, that was like a whirlwind information of this really, I thought it was such a fascinating case, but I wanted to open it up to see if anyone had questions about this case overall or any kind of the teaching points.
I think you're seeing stunned silence. That was so awesome. Thank
Yeah, I
you.
just talked really fast. I was so excited about it.
That's all. I think that was a great overview of a very fascinating case and hitting the highlights. And I think that it just goes to show you um, how powerful these frameworks are. And I think that if I were to add one thing about each of them, the first is if you're trying to prioritize which is the most common of that five-pronged framework in terms of an infection not getting better, source control is such a, I would say source control is by far and away the most common. You usually get the antibiotic, right? Usually you know the drug, but there are some nasty infections. And I think that our ID colleagues prioritize source control before anything else. So that's definitely a factor. And then I think it goes to show you whenever somebody comes in and gets confused in the hospital, it's usually a medication. So somebody walks in and is fine and gets confused on your watch. We are experts at giving people medications, very, very good at that. And so the timing there is a very powerful clue. Awesome. Well, 10 seconds for any questions to sneak in before we move on to Tuesday's case by Yasmin.
Robbie, I have a question. So you just mentioned the fact that most of the times patients become altered because they somehow there's due to the drug side effect that we give the patients. But how can you determine that it's not something like hospital-acquired pneumonia, for example? What makes you go to a direction, not the other?
Yeah, I think that that's probably down to the problem representation. If somebody has altered mental status and dyspnea, or altered mental status and hypoxia, or altered mental status and urinary retention, that landscape was a little bit different. But if somebody purely has confusion, it's almost always a medication. Really, really good question. So you still have to do your due diligence and still do the same missed schema. But the toxins, is so powerful because there are a lot of medications that make people confused. Awesome. All right. Yasmin, take it away, please.
Hey, so Tuesday was a super educational focus case by Dr. Gallen. Our short sentence of Tuesday case was 69-year-old male with history. The history is very important here. He has hypertension, heart failure with left ventricular low ejection fraction, cerebellar hemorrhage, and chronic kidney disease. Comes to the ED and presents syncope. Okay, so everybody started saying that, first of all, we have to see if it's cardiac, it's stroke, the patient. We were focused totally on this patient with the history, right? So the main thing we said as a very important teaching point is that hypertension is a risk factor for intracranial bleed, since he already had an episode, and we were thought that there's a target heart rate of 60 to 70 with carvedilol in chronic heart failure. Also, I also found that, should I say the diagnosis at the end? We found out that the issue with this patient was a right heart thrombus. But before we got to all this diagnosis, we were defining what do we have to look for in a patient that presents with syncope and has this myriad of histories of past history diagnosis. So we found out that first of all, evaluating POCUS, since it's a case of POCUS, we have to get more than one view when we are evaluating the heart, since one view equals no views. We started with the parasternal window long axis view with the rule of 3, evaluating the right ventricular outflow tract, the aortic root, and the left atrium, evaluating size and function and contraction. And also we had to find out about in this short axis, we found out the D sign, which told us that the D sign showed us that it was elevated right ventricular pressure. That's why we got it. So we started thinking, is it acute? Is it chronic? We started with imaging. We found that it was a thrombi. The issue with the right heart thrombus is that much of the difficulty making this diagnosis is due to the widest spectrum in manifesting features, which include syncope, undifferentiated tachycardia, shortness of breath, even shock, in many different permutations in between. So there is a really pretty article, I will share it later, that it says that the diagnostic modality for choice is the CTA. But in this case, if you had POCUS, if you had this available, this is what you have to look for, right? We didn't have time to discuss why this patient, where this thrombus came from. And I think it was Dr. Security that said that in the chat, that planted this idea on my mind, that this patient has chronic kidney disease. So uremic patients live in a state of chronic platelet blood cell activation. Let it be leukocyte, erythrocyte, platelets, everything. And because I also found another article that it's because this uremia causes this exposition of phosphatidylserine, creating a procoagulant membranous surface, facilitating this formation of thrombus. That's what I found in literature. That's why a patient that comes here, especially with all of this past history and chronic heart failure, we have to determine if he is, in this case, if he qualifies for an anticoagulant treatment. And also found out that patients with a low ventricular ejection fraction are more likely to undergo emergent catheterization with bypass grafting, CABG. So, and it depending on the how low is that ejection fraction, which is lower than 35%, they may have worse outcomes. So I think that the teaching point in this type of patients in real life is, what do we have to do after we control the main issue? Like after we stabilize this patient, what comes next? Because this patient at least has 5, 7, 8 years left. So what comes next for this patient? And using POCUS, always remember using this, it's stuck in my head. One view equals no view. You have to use the parasternal window line axis views, the short axis views, and always remember the rule of three.
Oh, so good. The rule of three. I didn't know that at all. That's completely new to me.
Me neither, but I really like it, so I wrote it down.
For sure. Rafa, you had a question?
No, just a moment.
It's a statement. You want to make your statement out loud?
Oh, it could be wrong, but this is something I learned a while ago, that very low ejection fraction, like Yasmin was telling us, is actually an indication for automatic defibrillator, because this patient have increased risk of arrhythmias.
Yes, that's exactly right. So if you have a low ejection fraction, you're at high enough risk of developing a malignant ventricular arrhythmia. However, putting a pacemaker in somebody is a big deal for many reasons. So what often happens is you try to give the patient medications for heart failure that will improve their ejection fraction, including ACE inhibitors, aldosterone receptor blockers, so on and so forth. So an ICD is only placed if a patient continues to have a low ejection fraction despite medical therapy for a few months. So that's usually how that's executed. Rukun had a great question about discussing a little bit more about what Yasmin planted of uremia and platelet issues. And Shema has a great answer. Shema, do you want to share your answer out loud?
Okay, so what I associate with uremia is, first of all, uremic frost. That's something like a spot diagnosis that I know, but I can't really explain it, but it looks really fancy.
Yeah,
Then also platelet dysfunctions, yeah. And also what we mentioned, like uremia can affect the heart, like think of cardiorenal syndrome. Also what Mukun mentioned, think of uremic pericarditis, and also of uremic encephalopathy, and also think of pruritus as an effect of uremia. That's all.
Amazing. Wow, so good. Questions, folks, before we move on? You know, both these cases are so rich that I'll take a moment to reemphasize what we were exposed to. And Madalena shared a great framework of how to think about patients who are not getting better despite treatment with antibiotics. And the questions are, do you have the wrong diagnosis? As you're completely off track. Is it the wrong antibiotic? Is it the wrong drug? Do you have a source control issue? Or is it a question of the patient's immune status? It's key. Many antibiotics cause people to get confused. Cefepime is one of them, but there are many others. And Yasmin just really highlighted the importance of recognizing thromboembolism as a cause of syncope, and also taught us the importance of the 3 views looking at the outflow tract, the RV outflow tract, the RV, and the LA to best understand that possibility. Cool. All right, Mukund, do you want to tell us about Wednesday, excuse me?
Yeah, sure. I will be very brief because I'm hoping that you all will help me build out one of my Evernote schema that's relating to this case, and we can make it a bit of a participatory exercise. But this was a case that was close to my heart, of course. 50-year-old man with uncontrolled HIV and unstable housing, newly on consistent antiretroviral therapy, presenting with a pruritic erythematous rash on the trunk and the arm, and another lesion on the right elbow. The final diagnosis was tinea corporis for the rash, and an abscess on the right antecubital fossa, most likely secondary to intravenous drug use. It was a great case, but I actually think that for today, I wanted to pivot a little bit and talk about something that came up a lot in the chat, but did not end up being the final diagnosis. And that is scabies, a very bread and butter diagnosis, but that still can sometimes be, or at least was for me when I was working, hard to identify because of all of the secondary bacterial infection that comes from scratching and excoriation, and just the severity of the symptoms that make it such an impactful diagnosis to help someone get over. Scabies caused by a little mite that hangs out in your skin. It lays eggs, it burrows around, and a really good way to identify scabies on a patient, especially if they have not been scratching it too much, is by using a Sharpie. So mark up, most likely it's going to be the wrist. That's a common place where scabies is found. You'll also find it on the back of the elbow. You might find it on the knees, in the groin, but the wrist is pretty easy to use and non-invasive. Just scratch the wrist with your Sharpie and color it in, give it a few seconds for that ink to settle into the skin, and then wipe the ink off with an alcohol pad. If it's scabies, you're very likely to see the burrow marks where the scabies mites have gone through the skin, remain in the skin, and they will be filled in by the Sharpie ink. So it's a cool diagnostic test. It doesn't necessarily get it right every single time, but it's a fun one to do, and I found that it helps. It has helped some of my patients kind of feel a little better about knowing what the diagnosis is when they can see some evidence of what's happening to them. Super brief teaching point that I wanted to go over was about a kind of scabies that I hadn't heard about, that was mentioned in the chat a couple of times. That was Norwegian scabies, or crusted scabies. Is a form of scabies that, as the name suggests, presents with crusted plaque-like lesions and oozing potentially, most often in people with some kind of immunocompromise. Notably, however, Norwegian scabies does not classically present with pruritus. And so in this case, where the patient was intensely itchy, potentially less of a concern, even though this patient did end up having a severe immunodeficiency. And this brings me back to the valuable teaching point that we've heard in many CP Solvers episodes, that even in patients with immunocompromise, think of common infections first. Rare infections are things that can happen to people with AIDS, but they are also more likely to get even the common infections. So start with your epidemiology and go outwards from there. As far as our exercise, I was really hoping that you could all help me put together a schema for rash and pruritus. Just toss out whatever you can think about into the chat, and I'll take some notes, and we'll put something together for my long-term learning, and hopefully yours as well. a broad differential, but there's some good stuff in here.
I actually have something to add to that schema. And I actually think Charmaine mentioned this during the discussion, which was like an initial branch point being, is this a primary dermatologic issue, or is this just a component of a systemic process? So I think she mentioned the example of, if you have jaundice and like indirect, I'm actually forgetting the underlying cause, but I think like elevated bilirubin leading to pruritus. So I think that's an initial branch point you can have.
Yeah, I mean, depending on our time limitations, maybe we can even just start by thinking about branch points for rash and pruritus. I guess if you count jaundice as a rash, then you've got your branch point there in terms of liver-related causes. There are some good buckets to start with: systemic process versus potential topically isolated process, right? Those could be some buckets. We love ID in this group. Other bugs that we can think about that would cause a topically isolated pruritus and rash?
I can speak about Brazil. We have what we call Ancylostoma brasiliensis. I don't know if you guys ever heard of it. But people, when they walk on the beach, they can get like this little worm. And sometimes you can actually see them, like they draw little maps. They're called geographic worm for a reason, because sometimes because they can't penetrate into the blood vessels, right? So you can see the rash, and sometimes it looks like a map. Yeah, it's cutaneous larva migrans.
Larva migrans. Okay, cool. Yeah, drug reactions. Speaking of drug reactions, something that came up pretty frequently in the chat was immune reconstitution inflammatory syndrome, which I'm not going to get into right now, but which was a great thing for me to learn about after the episode ended. Nice, good stuff happening in the chat.
I just jump in to say that it's actually pretty hard to figure out what to do when you have a rash and pruritus, because you actually have a philosophical question to answer first, which is this a rash that itches, or is this an itch that rashes? And what I mean by that is this somebody so itchy that they scratch themselves and get a rash, or does somebody have a rash that actually itches them? And so that is by far and away the most important thing to try to establish first. Is the primary problem a rash that is actually itchy, or is the primary problem a really bad itch that a patient scratches causing a rash? And really, really good dermatologists are actually do that effortlessly. Well, they'll be like, oh no, that's not a rash, that's just a really bad scratch. And so then you invoke your differential diagnosis for pruritus without a rash. Includes hyperbilirubinemia, kidney failure, some cancers can do it too. So yeah, I think that's the proximal question. But yeah, scabies is definitely on that list, and I think the ink test was very novel to me. I'd never heard that before. I find it really, really cool. I can't wait to try it out. I will text you a picture if I happen to do it successfully. Any questions for Mukund? Awesome job. Thank you for that great recap. The focus on something that maybe didn't turn out to be the answer, but certainly was rich learning involved in it, and something that all of us will see for sure. Really, really nice job. All right, Sukriti, tell us about Thursday.
Oh, okay, I'm unmuted. Sorry, apologies, I was listening to everything, but I was spending my time trying to get the frame, the frame set up for VMR, because I just learned that we can't have a good VMR without having some outdoor ambience. Like Sammy is outdoors right now, and I just made myself a berry shake. So you can't have a good VMR unless you've had you made yourself a berry shake like Robbie, and then like Mukund, and I'm going to say it shortly. You can't do a VMR without saying the word bucket at least once. So hopefully this will be a lot of buckets and berry shakes and lots of good oxygen. But to start off, Thursday's case was amazing. We had Ravi share yet another great case that surprised all of us. So we started off with a chief complaint of chest pain, and you know, we've had VMR for almost more than 2 years now, and it's weird because chest pain, you would think that after 2 years we would know everything about chest pain and that it wouldn't surprise us anymore, but we'd be mistaken, because every time I log in, I listen to a VMR about chest pain, I learn something new. So I kind of gloss over the 4+2+2, although it's really important, but I think that all of you would be familiar with it, and we can kind of drop that schema into the chat in case you aren't, which is on the website. So essentially that schema from CP Solvers, the 4+2+2, kind of highlights the basically the approach to chest pain, in which there are two components. One is the anatomic approach, and the other is kind of identifying the red flags and the etiologies of chest pain that need to be immediately addressed. So that's the 4+2+2. And then I tried to, we can't do a VMR without some sort of whiteboard. So I feel like I've been on here so long, I'm just morphing into everybody, but I tried to, let me see if I can get it. So essentially there are 3 parts to this. We're gonna do it in a 3-step way. The first is the problem representation, which here, and then this kind of ties into the whole discussion, is the, okay, so I think I'm not helping, but I will just, I feel like this should not go anywhere, but so essentially we're thinking about the context, the symptoms, and time. So the context was, this was a young female who had, Ravi told us some, history of psychiatric conditions. She had depression and anxiety. The timing of her syndrome, which was the chest pain, was acute, and the syndrome itself was chest pain. So that was our problem representation, and Valley kind of, with the additional history, she was able to extract the chest pain. She prioritized the lung and the heart, but she was able to extract that the chest pain was likely a result of some pathology either in the GI system, in the esophagus, in the thorax. And so she kind of honed on that and then used that to kind of think about her physical exam. So step 2, essentially, after we got the history and the physical, was framing the hypothesis. And then the other thing that I forgot to mention was that there were 2 things that we got from the problem representation and that Robbie highlighted. The first was that, what does the young age tell you with the 4+2+2 schema? So the young age, how does that change things? The only way that it changed how we thought about the chest pain was that it reduced the probability of coronary artery disease. That didn't mean that this patient couldn't have a myocardial infarction, a PE, a pericarditis. It just meant that there probably wasn't coronary artery disease. And then the other thing that Valet kind of highlighted was that, having one, how we think about autoimmune, and I think this is so important, like we think about organic diseases like autoimmune diseases, we say one predisposes to another. So you can actually think about that even when you're thinking about psychiatric conditions, like can depression and anxiety, could it kind of lead to a chain reaction where you're predisposed to other conditions? So this was how she kind of prioritized eating disorders in this young female patient, and then she used objective data to actually confirm that this patient was had a very low BMI, And so while framing her hypothesis, she had essentially done two things. She had used the history of presenting illness to make sense of the chest pain and prioritized the esophagus. And then the other thing that she did was to use the other additional data in the form of social history to think about what she could use to make a Venn diagram, and that was eating disorders. So essentially, while framing the hypothesis, hers was a Venn diagram between eating disorders and a chest syndrome. And then while thinking about this, I kind of looked this up because I didn't know anything about it. So there are two ways to think about eating disorders and essentially mechanical complications in the chest. So there are two ways that this could happen. One is from the point of view of malnutrition. So eating disorders lead to malnutrition. And then they say malnutrition causes reduced lung surfactant production. And that kind of leads to reduced tissue healing and increased tissue injury. The other way that this could happen is that you could have an eating disorder, and one of the consequences is you induce vomiting, and that can cause like a mechanical complication where you have esophageal rupture, you have raised in intrathoracic pressure, and this kind of has a fancy name. It's called the Macklin effect, which basically says that when there's alveolar rupture, there's increased alveolar pressure, and when the alveolar pressure exceeds the pressure in the vasculature, it causes dissection of the air through the thin walls into the interstitium. And then the way to think about that is it can go anywhere. So it can go into your pericardial sac. It could go into your mediastinum, causing mediastinum. It could even go into your epidural space, and there's a term for that. It's called pneumorachis, if I'm pronouncing it right, but you can look it up. It has a double R and an H. So that's kind of your how. And then like in CP Solver style, we're thinking about an illness script, there's the what. So essentially you can, in the what, the way to think about it could be that one important thing you want to do is to kind of exclude any visceral organ injury. So you might ask, why do you want to do that? Because it changes your management. Because then you'd want to get the surgical services involved, because you probably need surgery for that patient. So that's something to remember. And then you could also think about, as part of the what are the complications of this syndrome? So you could have inflammation in the chest. So you could have pneumomediastinitis. You could have you could even have pneumonitis. And then if you're thinking more chronic, so this patient came with a very acute presentation, but what if we were to change the timing? If we were to change the timing to chronic, then they can even develop fistulas, so that they could be alveolar pleural fistula. So that's the kind of how we frame the what part of this illness script. And then just the last, maybe I'll just go through this quickly. The differential, we're always thinking about differentials. So for spontaneous air leak syndromes, you think kind of using the base rate, you're thinking exercise, retching are some common. The other is you start to think about, whether there's any underlying lung disease. So any sort of underlying lung disease, especially like interstitial lung disease, asthma, COPD, cystic lung lesions, malignancies, these can predispose you. And one thing that I learned when I was going through this was HIV. HIV as well can predispose you to developing bullous lung lesions. So that's another sort of thing to remember. And then, I think I saw connective tissue disease in the chat. I think I missed that one. And then finally, the treatment, which is basically conservative treatment until the source of the air leak resolves. That's what Ravi told us during our case. And then just to wrap this up, in that 3-step process, we went through framing the hypothesis, the problem representation, and the last is testing the hypothesis. So I think something that I learned from Ravi and Reza is basically when you're thinking about testing the hypothesis, you're thinking two things: base rate, and then what is the patient's syndrome. So here Valley did, initially when she got the aliquot with the chest pain, she prioritized the lung and the heart disease as a cause of chest pain, which she should because of the base rate. But then Ravi reminded us that every patient with chest pain gets this basic workup, right? Of the EKG, the chest x-ray, but when do you want to go beyond? When you want to go beyond this testing? And that's when the patient's syndrome comes into play. So here, the HPI kind of made us think about what could be going on outside of the heart and lungs. And so we thought, given that acute presentation, we layered that on, and we said that the best test here to order would be the CT scan. And so that will kind of help with everything. So I feel like I have been rambling, but it was such a great case and I learned so much from it.
How could you not go deep dive into this case? It's unreal. I was giggling at the end for many reasons, especially because you inspired so much reflection in the chat that Yasmin shared an article in French, which, if you know Prof. Rez's current obsession, it's just amazing. But on a serious note, Sukriti, that was amazing. It was such a great recap of an entire illness script of a very rare condition, pneumomediastinum. And I think for me, that my biggest takeaway was, how is it possible that you can have air come into the mediastinum and never know where it came from? Right? Like the idea of spontaneous mediastinum that you were finishing with, the idea of connective tissue disease and stuff like that, including the patient. You took a picture of her CT scan and you have no idea where the air came from. And I think it illustrates the concept that you don't have to have a breakdown of a barrier for air to leak past it. So if you're air in the lungs and the mediastinum is right next to you, by sheer virtue of pressure alone, can you force the air across the alveolus without breaking the alveolus? It's also true of water. You can get an effusion in your pleura without breaking the pleura. Water just seeps out. And so air in each individual air molecules can go past the alveolus without breaking the alveolus. So it's really, it was like a kind of a earth-shattering concept for me to say, how can air get past something? It doesn't have to break it. The sheer pressure can have individual air molecules go by, accumulating in the mediastinum. And that it's much easier for pressure to accumulate in somebody who has a weak connective tissue and things like that. So it was really, really awesome case and a great illustration of it. Thank you. And by the way, the whiteboard gimmicks was just, oh my God, that's just perfect. We were watching the Sukriti show and learning along the way. It was really cool. Thank you. All right, Rafa, take us home.
Okay, the last one, because I didn't want to be skipped. Okay, so this is we had an incredible case by Ravi again on Friday. Ravi saving us like usual. So this was a 50-year-old male. This patient had a past medical history of recent motor vehicle accident, diabetes, hypothyroidism, and he presented with worsening right shoulder and chest pain for a week. And his MRI revealed subdeltoid bursitis associated with abscesses, and blood cultures came back positive for MSSA bacteremia. So all my teaching points were being about what Dan taught us. Sorry, Ravi and Reza. And this is about what Jen taught us about staph bacteremia. So the first teaching point is that you have to ask yourself when you're dealing with a patient with MSSA bacteremia is where it came from and where did it go? Because that allows you to have like a timeline for your patients. And this is very important because you want to know for how long this bacteremia has been going on. And the question is why? And this is because as chronic as it gets, your patient is more prone to have certain complications, such as endocarditis. Would you like to add something, Ravi?
Well, I think that's absolutely perfect. I didn't know that from Dan about how important it was to know when the bacteremia started. That was really powerful. Yeah, no, nothing to add.
Okay, and the second teaching point is when your blood cultures come back positive and you know the timeline, the next thing that you want to ask yourself is, go to the patient and ask, do you have any symptoms at all? So if the patient says, oh, I have this mild back pain, and the back pain could be due to a problem because you lay wrong in your bed, for example, like then I joked, but it doesn't matter. Your threshold for an MRI, for example, would be much lower for this patient than for the other patients. Because if you miss like a epidural abscess or vertebral myelitis that could be going on to this patient's bacteremia, that could lead to a poor prognosis, function disability, and even relapse. So I think it's really important, that teaching point as well. And just to add another thing that I learned going through some articles, the most consistent predictor factor of mortality in these patients is actually age. They said that, for example, ethnicity, socioeconomic status, it was unknown. They couldn't like say, oh, this one is worse for the patient, this one is worse, but actually, as older the patient was, the worse was the prognosis. And that's the end.
No, it's amazing. You're like, essentially, you really need to know where it came from, where is the source, and when was the source, and where did it go. And I think that is a really, really hammered point of where did it come from and where did it go. So powerful. And honestly, sometimes it's really hard to know where it came from, and sometimes it's really hard to know where it went. So thank you for emphasizing that. That was amazing. You know, you can never have a VMR recap session without hearing the wisdom of Shema. And so she's going to share with us her favorite pearl of the week. Shema, what stood out to you the most?
I have to say my favorite pearl was basically something from the POCUS VMR that I got to discuss with Ravi. And Sammy already knows the answer because I sent a POCUS video, and without hesitating, he told me what it was. It was this McConnell sign that you can see on POCUS. And I have to say, I only heard of the D sign that you can see in the parasternal short axis. And I never heard of this McConnell sign before. So it's basically that we have a right ventricular abnormality, like the emotion abnormality, but we see a hypercontractility of the apex. And I didn't know that. And there was truly an amazing teaching pearl for me that this could help us to see whether someone has acute pulmonary embolism, because it's a specific sign. And my second teaching pearl was, I have to say, I never associated syncope with pulmonary embolism. And it will make me realize to think of it always, because it's such a common disease. And I will always say now that pulmonary embolism is a chameleon. Yeah.
Yes, Reza would be very, very proud of that. The great imitator and the chameleon. Yes. Oh, it's amazing what we covered in VMR. Went all the way up to otitis externa in the brain with cefepime-induced neurotoxicity, and then had a patient who syncopized from a pulmonary embolism that was caught on POCUS, and learned from Yasmin the importance of the free view she emphasized. And then we had a really bad itchy rash, and Mukund taught us to always think about scabies in that situation in a really nice way of looking simply for the possibility of scabies, and we'll call it the Mukund ink test from now until the end of time. And Sukriti walked us through an amazing illness script for a very rare diagnosis, pneumomediastinum, and highlighted the importance of getting imaging in those patients to really understand what exactly happened. And then Rafa, the key question, where did Staph aureus come from and where did it go? It's so important. And yeah, Shema, I completely agree. I think that pulmonary embolism is the most mysterious condition I've ever come across. It can be asymptomatic, it can cause shock, it can cause mild shortness of breath, and it can cause syncope. I think there's nothing that PE can't do. And Rafa presented a case of PE causing fever and abdominal pain, which is why I like to skip him all the time, because he presented a case of PE causing fever and abdominal pain. But anyway, thanks to you all. Had a great time this week, and appreciate you guys recapping it. I'm going to stop the recording now for the folks on YouTube. Thank you.